Very good.
We can flip the lights.
Okay, we're going to just go ahead and jump in and get our speaker started. So this is WFAHA, in case some of you, maybe 2 or 3 of you have never been. Western Fairfax Advocates for Healthy Aging. We've been meeting since March 2012. We took a little 14-month hiatus just to get a little time off. And I'm going to introduce Mary Ellen Kinnett, private citizen, florist extraordinaire, and she is going to introduce our speaker.
Well, I was going to say our speaker needs no introduction, but I'll give her a short introduction because she said she doesn't like us to talk about her too much. So this is Denise Sobel. And as many of you know, she is the director of case management at Reston Hospital Center and market development.
And Stone Springs Hospital.
And Stone Springs Hospital. And market director?
Yeah, because I'm over two hospitals.
Oh, okay. And market director because she's over both hospitals. She has been a nurse for, I never say how long I've been a nurse for because it's frightening. But she's saying 35 years. I think she started quite young. 36. And case management for 10 years. Yeah. So we're happy now that she's at Reston right in our backyard. And I will turn it over to her. Be thinking about questions you might have for her.
Good morning. So nice to see everybody back in person, and I can see your face. It's fantastic. So thank you for inviting me here. I had a different thing in my mind. I used to do speaking engagements when I was at Alex, and we were talking to seniors in the community to answer questions for them about post-acute care. So I understand that all of you are partners in the post-acute care setting, which is fantastic. And I bet a lot of you are wondering how you can access case management at Reston and Stone Springs Hospital. No. Well, I'm going to tell you. First, let me go into a little bit. I don't know if many of you understand. HCA Reston Hospital and HCA Stone Springs Hospital are part of an international healthcare organization that spans across the entire country and into the United Kingdom. They're the largest employer of healthcare in this country. So we have a long outreach of resources and best practices and all these wonderful things that we can grab onto from our other division partners. It makes us a very strong leader in healthcare, and I'm very proud to be a part of that. So last year we had this unfortunate thing go down where the country shut down. And as of, I believe, March, when Julie bailed on us, we underwent COVID restrictions. So, nobody was allowed in the hospital. Visitors weren't allowed in. Unfortunately, even for our end-of-life patients, vendors certainly weren't allowed in. And it made it a really hard time. It made it a hard time for us. And it made an equally hard time for you because you couldn't access us. And we could only access you by phone. Not really the relationship that's going to work well for an ongoing partner continuation, right? So thankfully, I can say during that time, I will tell you, our hospital was empty. We had COVID patients, but that's kind of it. So the hospital was empty. But thankfully now our surgeries are back, and unfortunately, the hospital is exploding. So our census is very high and has been high, I think, since February, right, or January. I think the December, January, February, March of this recent December was our worst COVID time. We had the highest acuity, we had the most patients. It was a very challenging and difficult time, I think, for all the hospitals in this area, really. And certainly as we find out from our partners across the country in our organization, they also were having a hard time. But thankfully that's dwindled down. And so I think on any daily, we might have 1, 2, maybe 3 COVID patients in our building. So we no longer need an entire COVID wing, which is fantastic. Our surgeries are back up to pre-surgical status before COVID, which is also fantastic for the patients who've had to put off their joint surgeries and their elective surgeries because they couldn't get in the hospital. In addition, I think all those poor people that weren't able to get that care are now also coming in, and the acuity is much higher. All of you in the community know that patients leave the hospital much sicker than they have been in the past and generally need more services, right? So I know we have hospice and assisted living and home health and SNFs and LTACs and acute rehabs, all trying to make sure that they can provide care for our patients. The great news is visiting hours have been lifted. Patients can have 2 people in the room unless they actively have COVID. And then it's on a case-by-case basis, or if they're end of life. But anytime a vendor comes into our organization, remember that you have to come through us and you have to be credentialed. HCA is very strong on making sure all of our partners are credentialed. So we know they've been vetted to really be in the hospital. And, that vetting includes, flu tests and TB tests and stuff like that. It can be a daunting process, but it's really for the safety of all of our patients. So how can you guys access us? Well, we use a referral system called NaviHealth. If you are not on NaviHealth, we're not going to be able to refer you because that's our referral source. So NaviHealth is I would imagine you'd go and get a contract for that, right? And then when we send referrals to you, it's electronic. Everything's great. It's electronic until it doesn't work and it's not so great. So we send all those documents to you electronically for you to review. And the key for any vendor that I tell that wants access to us is I need you to be on NaviHealth. Because what we do, CMS makes us give choice lists for patients for their care. When you're a Medicare or Medicaid patient, you have the right to choice for your post-acute care. Everybody should. And so we run those lists. There is no special magic provider list. There's no log me into your list. It's not that. We pull up a list in our NaviHealth system based on the patient's zip code where they're going to go at discharge, and we run that list. The great thing about that list is it gives that patient and his family the CMS rating for that facility or that service, knowing that acute rehabs do not get CMS ratings and nor do LTACs, but the rest, most everybody else does, especially from home. And that's how we focus our patients to get your services. I think that we have had some challenges. There's a way to have NaviHealth where you don't buy the contract, and that means you're not connected to us, and then you have to go through an email and read all this encrypted stuff. It makes it more difficult. And for us, it's actually extra work for us to send you those referrals. So if you really, really, really want to partner up with Stone Springs, with Reston, and I'm sure there's other hospitals in this area, not the Inova uses Allscripts, but the rest of us use NaviHealth. And I really would encourage you, if you really want your voice and your services out there, to really get into that contract of a NaviHealth, and you would do that on your own facility. And that lets us know that you're there too, and gives the patients your name for a choice to pick from. So if you get a referral from us and you're interested in coming to meet the patient, you're going to accept the patient, you're either hospice, home health, whatever, then you would need to contact us, and there should be a phone number that comes through on NaviHealth for the case manager that sent that referral. You would call that person and ask if it's okay if you come in and see the patient. Not all patients want 80,000 vendors in to see them, but we vet it through the patient who then gets to come in and make that contact. The great news is you guys can come in and make that contact now. You can have that face-to-face interaction. So who do we primarily discharge to? Home health, definitely. SNFs, definitely. Acute rehabs, yep. Assisted livings are a little more time challenging because you guys have a lot more documentation that has, I'm not saying it doesn't happen, but that's a lot more time challenging. A general dispo from a hospital is generally not assisted living because it's private pay. I can't run that through Medicare or Medicaid or whatever Blue Cross they have. That's a coordination with the family. And because of the timeliness that we are required to make sure we do expeditious discharges when they're ready, sometimes assisted living may or may not play into that. But that being said, we'd love to partner with all of you guys and see if we can streamline that process. A lot of our patients, as you guys know, would do exceptional in assisted living. They may not need to go to that SNF, but they're not quite ready to go home. So getting the word out to you guys earlier, if that's the route the family goes down, then we certainly want to partner with you to see how we can expedite that process into your facilities. I know somebody had a question, how do you all from the community get into our acute rehab, right? So let me explain about acute rehab. You know, many of you may realize, let me just give you a little tidbit. Acute rehab is the most intensive form of rehab a patient can get. It is 3 one-hour sessions a day, 5 days a week. Very, very, very strict requirements to get into acute rehab because they have regulations they have to follow too, right? But that doesn't mean those patients can only come from a hospital. If you're in assisted living or you're a SNF and you see patients for assisted living have deteriorated, multiple falls, but they really don't need to come to the hospital, you can reach out to our acute rehab directly. It will require a little more legwork, getting physical therapy consults, things like that, and then referring it to our acute rehab so they can evaluate these patients based on the criteria, right, that they have to meet to get the patient in there. Certainly, if a patient comes to you and they're in a SNF and they've done amazing progress, but they're still not quite ready to go home and start dragging out those stiff days to increase their rehab potential, you could also send that referral to our acute rehab. Good news about our acute rehab is we were just approved by Richmond for our certificate of need, and we will be increasing our acute rehab by 12 beds, which will give us a 30-bed capacity, which is fantastic. We need more acute rehab beds in this area. I think the next closest is Aldi, and then you have to go to VHC or Mount Vernon. So having more acute rehab beds is going to be paramount to really getting those good outcomes for all of our patients. And just because they're not in our hospital doesn't mean that they can't access our services. What can I answer for you?
I'm Heather Surrey, Aging Life Care Manager.
Oh, I see you on Facebook or LinkedIn all the time. Hi, nice to meet you there.
Home care. Almost all of our clients, our care management clients coming out of the hospitalization are going to need home care, in addition to home health. So since home care is not Medicare, are you still, can home care companies still register with that? How are we getting those home care referrals?
So you can have a private company. You don't have to be Medicare certified. They'll vet that out, and that'll be in your profile. Are you talking about skilled care, or are you talking about unskilled care?
The non-medical home care. So what I'm wondering is, are your case managers running non-medical home care lists from having for clients who are doing non-medical?
So no, that's in a separate thing because we don't refer to private home care because it's private pay. Not that we can't. Julie, do we have that capability? Yeah. So you're not giving them a list. We're giving them a list. It's just not from Navy Health.
So how do we ensure that we are on that list?
You call me and I type it in. And if you have updated information, call me so I can type that in. Because the last thing families want to do is call numbers on this list that are not valid, right? That's a waste of their time. A lot of the private duty companies have also given us like brochures that we can give to our families and patients, which is, we have a whole brochure rack. We can do that as well. But for that, we need to know, are you Medicaid? Do you do Medicaid, or is it all just private pay? So we can relay that critical piece of information also to our patients and families.
Do you have sitters, private duty sitters in the hospital?
We do not. The sitters that we have in our hospital are actually employed by the hospital for liability reasons. That being said, we do have patients in the hospital that have private care companions at home that come and stay with them in the hospital. I'm not sure why, but they do, if that's their comfort level. They've known this private duty person for a long time, but an actual sitter has to be hospital employed for liability reasons. What else? What else can I help you guys understand?
Could you say something about transitions of care? Right now, people can come in, meet the patient, meet the family. And we all know that the key thing for the hospitals is to prevent those readmissions. Is there anything around that else you'd like to say?
So, right, I'm sure many of you in healthcare realize that readmissions is a really big deal. Certainly Medicare readmissions with, you have actually 7 core diagnoses: cabbage joints, heart failure, pneumonia, sepsis, something else. COPD. I said joints. Anyway, there's another one. Medicare dings you significantly if you bring a patient back into this hospital in 30 days. As of in the last, I believe, year, it's not just hospitals that are being recognized for that readmission. It's home health companies. So our home health companies that we partner a lot with start to give us readmission data every month, and how they keep patients out of the hospital is paramount in this day and age with Medicare reimbursement. At one point, it was just hospital reimbursement, but now the SNFs get dinged for it, the home health companies get dinged for it, of course, all your acute rehabs get dinged for it. So it's really a big deal to put in process a very good plan of how you're going to keep these long stay patients, these chronically ill patients, managing their care at home so they don't have to come in the hospital. And it's not even about the penalties for the organizations. It's about the quality of life. If you're a patient spending every other week in the hospital, that's not quality of life for your patient. And so we have to really figure out a process how we can effectively manage them at home by giving them good quality of life, maintaining their medical management, and trying to keep them at home healthy and safer. And there's a lot of new programs for who's a home health company? Home health. What agency? Cavalier. Who's ALF? And then where are you guys from? Where are you from, sir? Comfort Keepers. Okay, so private duty. Okay. Who hasn't raised their hand, and where are you from? Glad to see you. I'm sorry? So you have a great, yes. Yes. Yep. So we have a nice range of post-acute care providers that are present with us. And I think our takeaway right now is, how can you access us, right? Get Navi Health, call the hospital, ask for the case management department. If you have a patient that comes back to us, call us and let us know that, because we may not know that. And to be honest, half the patients can't remember the name of your company. They'll remember the name of your fabulous, therapist, but they may not remember the name of your company. And there's some agencies, I'm going to tell you, and their home health is very good. They call us immediately when a patient comes in, right? And so we know where the patient's going to go back to, which is important. Do you have a question, sir? No? Yes, ma'am. Absolutely. So you are correct. We have a contract with Vitas Hospice for general inpatient care. So when you are a hospice patient, and for a lot of our patients that go with what's called GIP, it's kind of like an end-of-life situation, generally speaking. And I mean, Capital knows all about that. They have their great inpatient centers. So currently, Vitas is our provider. But to your point, when a patient is going home with hospice, they get the whole list because it's important that they get a choice. And in fact, we've given you several, I think, in the last. Yes. Yeah, because it's the right thing to do. Patients have a choice. Just because I may have a contract with a GIP provider does not mean that that's the only person who's getting our outpatient business. And I will tell you, and hospice can probably agree with me, GIP is not where the revenue is for hospice, it's home hospice. And so we have to be fair in who we make our partners with. Partnerships are very important. One person, one provider, one vendor cannot provide the services for all the patients that we see every day. Who else has a question?
All right, I know it talks a lot. This is a two-part question. All right, they talked a lot about how much money they, how much pro bono work they do. And I just wondered if Reston also does pro bono, and how that works.
Charity care?
Charity care, and then what kind of charity care might you be looking for? And, and I can say that home health has some parameters around that with Medicare, but would you say something about that?
So, right, so Reston and Stone Springs are not much different than Inova. I will tell you, let me share some difference. Inova is a nonprofit hospital. The HCA healthcare organization is a for-profit. Do you know what the difference is? We pay taxes. Inova doesn't have to. That's the only difference in care. We do charity care within our organization, just like Inova does. I think that goes back to like government funding for hospitals and agencies and things like that. So yeah, we do charity care for our patients. We have to. It's the right thing to do. You're not going to send a patient out who needs IV antibiotics if we're not going to pay for it, and then they're going to get septic and come back in and potentially die. We do charity care just as well as Inova does. Now, we are fortunate that we have partnered with some home health agencies that actually also give some charity care for home health visits. I myself have contracted for some home health to get a patient home safely, especially during COVID. The whole family was having COVID and we had to take care of her. So we do charity. It might structure a little different. We're not going to be charity paying for people to go to skilled rehab for months at a time. That is something we don't do. We look for alternative plans and then put them in place. Yes, ma'am. So, right, that's a great question. So, Olivia asked, about InServicing, coming in and sharing your information about your organization, your services with our team. We welcome that. There was a limit that vendors can only come in and talk to us for like 10 or 15 minutes. And our way around that, our way around that is by them bringing us lunch and joining in service. That way I can say to administration, we're getting an educational and service from this vendor that will help our team grow. And then they come in, they give us their services, they tell us all about them, what insurances they take, if they don't take insurance. They give us the key points to it that our team hears in person so that they can move forward with helping other patients understand what that particular vendor can do.
What's the status of expansion at the hospital? What's the plan for the coming years in addition to the increase you have?
So Rustin's doing some pretty exciting things. We are expanding to a freestanding ER in Tyson's Corner. I think there was a Korean barbecue there, and now it will be a freestanding ER, which is fantastic to help these patients down in Tyson's. Of course, we're increasing our acute rehab beds. We're doing a complete remodeling of all of our inpatient rooms. We're expanding our surgical services, our maternal child health area. We are one of the leaders in this area of robotic surgeries. We have some of the highest technology out there and more of it for our orthopedics and our other surgeons to perform very complex robotic surgeries, which, if you didn't know, increases your opportunity to heal better, to get more mobile, less pain, less complications, which is very exciting. So our OR surgical services are expanding. Our maternal child health are expanding. Our inpatient rooms, we actually are looking at remodeling some areas and including more inpatient rooms. Currently we are a 231 bed facility in a level 2 trauma center. We're the only level 2 trauma center in this area. So it's important that we have beds to access all of our, to accompany, take care of all of our patients that come in our door. I think that expansion plan is going to be over the next several years. But I think they've already broken ground or very soon going to break ground on the Tysons. And then I think our inpatient acute rehab starts, I believe, at the end of the summer to redo those ones. Stone Springs has also been really growing. So many of you may not realize, I think Stone Springs just celebrated its 5-year anniversary. They are greatly increasing. So many of you that don't know the area, so that's out in South Riding. When Stone Springs was able to be approved to build a hospital, they started by building a freestanding emergency room. And across the parking lot is when they started the hospital. So right, that freestanding ER is no longer there because, well, we have a proper ER with a hospital. What they're doing with that freestanding ER is they're making that an outpatient surgical center to help all of our surgeons out there provide outpatient, like same-day surgery care for their patients. In addition, we will be opening an inpatient psych facility within the Stone Springs Hospital. I can't remember how many beds, but it's significant enough to help the area. You know, this other than Dominion Hospital, which is also part of the HCA family, there is a significant decreased shortage in mental health beds, as many of you probably are aware. The Stone Springs program, along with the Dominion programs, offer inpatient, adult, eating disorder, outpatient, what they call day clinics, where the patients go there for the day, but they don't stay overnight. So the range of services that our psych facilities have are pretty impactful to the community. And we're really looking forward to Stone Springs opening. I think they said they would be opening in the late fall, maybe November-ish, barring construction goes well.
Lamps, quit taking seniors after a while, but is Stone Springs going to take seniors?
So we take all patients, right? I remember Lamps was Loudon, Sagal, Medical, Psych, or something like that. And I didn't know they stopped taking seniors, but you know, our seniors, especially now, the mental health impacts that have taken onto our seniors and our children from COVID isolation is hugely impactful. For those of you in the community that see these seniors, you feel it, you see it. So yes, we do take in patients as when they're appropriate. And remember, so we also have psych hospitals further down south in Virginia as well. I think there's one at Lewis Gale. Spotsy has one. So we have a huge network in the Virginia area of HCA hospitals that if we can't find you a bed here, we probably can find you a bed, at one of our facilities. When we do place psych patients, just so you know, we don't just place them at HCA. We look for a bed at a psych facility, preferably if we could, around where the patient's desired address would be. They want to keep them close to home. But if not, because we're such a big organization, we do stretch far down into Virginia, so we have greater opportunity for resources. No. The one thing that it comes down to is when we reach out to one of our post-acute partners, timeliness is everything when you respond. If a lot of times, right, I can't wait a day. If we're surprised that we start discharge plan at the day of admission, but let's say 3 days into it, our initial plan of coming home with home health has now changed, and now we're looking at a SNP or assisted living, and we reach out. Timeliness is everything. The more timely you can respond and move the process along, the more likely it's going to be a better partnership. We have metrics. Hospitals have metrics. You all have metrics. It's our report card. And one of our biggest metrics is our length of stay. Managing the patient's care in an appropriate amount of time to deliver them quality of care to where they're safely medically to discharge. So, Navi Health and timely response in your goal. What else? Yes, ma'am. Say it again. I don't think so.
Okay, just one emergency, and I just wanted to thank you for your response from the Texas was off the charts. Between you and Olivia on Hospice, what was accomplished in a 4-hour period was amazing, just amazing.
I'll certainly tell the team that I didn't have to discharge anybody last week, but I will give that feedback to them. I had this week though, because it's been so busy. You know, and that's what a partnership looks like. Us working together, putting our heads together, making timely, effective discharge planning, getting our patients where they want to be in the time frame, particularly with hospice. You know, I think of all of our clientele, and this is just Denise Sobel's opinion, which really doesn't count for anything, but of all of our clientele that need the most seamless and caring and uncomplicated discharge is our patients going to hospice, be it inpatient or home, because we know why they're going to hospice. And that is a hard enough decision to make anyway. So the fact that that should be the absolute most seamless transition is paramount. And you guys exemplified that perfectly last week. So thank you. I'm very fortunate. We have some great team members and are always adding. As the hospital grows, we have to grow too. And we're being pretty picky with who we pick, and it's a pretty exceptional group of people. I encourage all of you to give me feedback at any time, either what we could do better or what we're doing well, so I can share that with the team. They love to hear from the community of things that they can improve, or even if they have to do something right, they like that too. Yes, sir.
So all employers, including many of us, are facing difficulty hiring people right now. There's a labor shortage. How is that impacting us?
So you think there's a labor shortage for you? Try find a nurse.
Well, exactly.
So our biggest challenge is, yeah, slacker, the other one over there. So, right, one of the biggest challenges I'm finding in the case management world is there is such a shortage of case managers and nurses that these travel companies are paying them a fortune to go do the same job for 13 weeks that a hospital needs them to do. And so it is challenging. I've been fortunate. We recently just opened some new positions, and I think I had 3 or 4 positions to fill, and I got some outstanding candidates. I'm very, very fortunate. We vetted through a whole bunch of them to get those 4 candidates, but it is a challenge. I know that our hospital went through, just like many of you do, challenges with staffing, certainly after COVID. Well, we didn't lose a lot of staff, and let me just share this with you. HCA did not lose a lot of staff from COVID, which is fantastic. HCA did something pretty remarkable. You know, remember I said the hospital is empty? Well, nurses don't work. Doctors or physical therapists, all your insulin, nobody works if there's no patients to support them. But what HCA did is they paid them 70% of their pay if they couldn't work that day, which is phenomenal. Where other organizations around us were laying people off, we were paying them just to hang out and stick with us until we got through this. And so therefore, during COVID, thankfully, our turnover was pretty low. But as we grow and need to increase our positions, finding those permanent staff people is very challenging. They have been able to fill most of their new positions that they've opened. But it's been a process. So we can feel your pain trying to find people to work for you. We wish you luck. If we find people that might fit your bill, I'll shoot you an email. I'm always looking to help our partners too. Because if you're staffed, you're going to help our patients, right? It's all a partnership. Anybody else? You guys came here not with any information? That's fantastic. That's great. Is there people in here?
If anybody is asking a question online. Yeah, no, we're okay. Oh, we've got a bunch of people on there though.
Oh.
Hey, everybody. You can type in any questions in the chat. Okay, thanks.
Yeah.
Okay, a sort of question. So some of the senior communities have programs of, I think, a I'm not promoting anybody, but I don't know if Reston still has the road home, but some of them have.
The Sunrise,
Yeah. they're saying
Reston, we don't have that, but Sunrise does.
Yeah, so, are those programs valuable to you? Like if, say, here was a, opportunity to put someone in at a reduced rate as opposed to a SNF or something?
Yeah, so that's a great question. So what Mary Ellen asked is, and I see Dana left, the Sunrise has a program called a Road Home. It's kind of like a respite program where they can go, still get their therapy there. Not quite can hang on their own at home, but it helps get them where they're not quite needing a SNF. They're in that yucky in-between area. So programs that have transitional care like that, and they greatly reduce those fees for our patients. Remember, no insurance pays for that. That unfortunately is a thing of private pay. So if you have programs similar to that, we certainly want to know about that so we can give them. I think other than Sunrise, is there another?
Hunters Woods does that, and coupled with home.
And Tall Oaks does it as well. Yeah, and we've actually utilized that for a couple of patients. So yeah, if you have programs like that, I want to know. Dr. Gordon? That's great. So those of you that don't know, physicians that are over in acute rehab are actually specialists called physiologists. And so they specialize obviously in physical medicine. So that's fantastic because they're getting a max amount of mobility, services, and they're being recommended for what they need. That's fantastic. I didn't know that. That's great. I think they were also seeing patients at Potomac, maybe, I don't know. They were at one point, I don't know if they still are. What else can I tell you? If you want to give me your business cards when we're done this, and we can talk about other opportunities of how we can get you guys in here to get FaceTime with the team. It's a great team. I think you'll enjoy meeting them. They certainly want to hear what's available out there. We think we know, but there's new things that happen all the time. So the more information you can give us and keep us updated, the better all of us can serve our clients in the Reston area. Okay. Yes, ma'am.
Oh,
Yes, ma'am.
Lisa Smith.
Hey, Lisa.
How many are case managers, social case managers?
Now you can make me do that. I can do it the other way. So we have a team right now of 21 people, 21 team members. Of those, 2 of those do, I don't know if you're familiar, 2 of those do the insurance portion. So when a patient comes into the hospital, and we talk about status, and patient and ops, right? Big deal, real big deal. It depends on how they're going to get billed, and it depends on what services they can get afterwards. We have actually 2 in-house people that do our Medicare and our observation patients and our uninsured. We have an entire team, because remember, HCA is huge. That sits down, I believe they're in Richmond, they do all of our commercial payers, right? So they make sure that we are moving patients into the right status and getting them to where they need to be. Lisa, what was your question again?
Was that like utilization?
Yes. And then thank you, because apparently I need my air set today. So the rest of them, except for, I'm going to count my fingers, 1, 2, 3, 4, 5 of those are social workers. 2 of those are licensed clinical social workers that work with our trauma team so that we have that expertise on our trauma team service. And they rotate through that trauma service. And then the rest are nurses. So 5 out of 21 are social workers. But our case managers, Lisa, that might be why you're asking, is our social workers and our nurse discharge planners are both expert at doing the social work part as well as the nursing part. We are all doing the same. We're all doing the same thing, which is fantastic.
So you guys don't necessarily, the social workers focus on placement and the nurses do
Correct.
help and infusion.
Right. some facilities, right, they have a social work model where all the complicated social discharges, which we have had a ton of since last year, just unbelievably a ton. No, we don't divide those social work pieces out. We make sure everybody is expert at doing all of it, because it's easier, instead of having, 12 horrific people to try to place and get guardianship and do this and do that, we can spread that out evenly so everybody gets good quality time with all their patients. That's a great question. Yes, ma'am.
So, you want to share some data, you mentioned that some of your partners share on a monthly basis data points with you. Wanted to do the same. How would you prefer to see that information?
You can send it to email to me or to our manager. We have a manager that's also between two hospitals. Her name is Demi Ong. And then what we do is we actually share that, especially for your criteria. We have a whole readmission committee at the hospital, and we have to share that with our senior leadership of how well our partners are helping our patients. So any data that you have from a readmission focus, from a quality of care perspective, that's you guys letting us know what a great job you're doing. So share that with us, because we can share that with our patients. And we do. We really do. Anything else?
I think,
I think he was just asking me if I.
Yeah, it's just happy to share more about the road on. Oh, when you're talking about the Sunrise program.
Right.
So.
Who else has a program besides Tall Oaks in here that is more like a short-term respite program with reduced rates? Your Harmony? Kensington, that's right. Right. That's fantastic. Give us information on that, right? It's expensive to come to assisted living. It is. It's great care, but it's expensive for regular people to pay for that. So when they hear that you guys are offering a program that is going to reduce their financial responsibility, but giving them the experience that they get at these great facilities, we want to make sure they know that. And that may lead to further referrals for all of your facilities as well, right? We're not expert. We can't speak to your assisted living care. We can't, but we can get them to you so you can tell them what you do so well. Short-term stays are excellent, especially there is one place that a lot of patients do not want to go right now. Where is it? It's snow. It's unfortunate, some of them need it, but they're declining from it. They're afraid of it. For whatever reason, they're afraid of it. I will tell you that our SNF partners have done an excellent job during COVID in making sure that these patients are on screen or they're put in isolation as soon as they get there. So I do feel pretty confident in sending our patients to skilled facilities at this time. Right? And I'm sure that you all have also put implementations in practice. Who here takes active COVID patients? COVID patients. That's a big thing. If you test positive, and our COVID patients right now, thankfully, are not that sick. But finding a provider who has people that want to go into that home can be challenging. So it's good to know as this pandemic, hopefully, starts winding down a piece, that we can expand those services and maybe look at the acuity of your COVID patients versus whether or not they're just positive. We have some tested positive that are asymptomatic, like that are pre-op, just for pre-op, for standard pre-op. So maybe talk to your people at your vendor and see, do you need to relook at your COVID policy? If they're asymptomatic, Maybe just a thought. Yes.
Correct me if I'm wrong, are you guys offering the Johnson & Johnson COVID vaccine and have to be admitted to the hospital?
Right, so when we were first vaccinating the employees, right, we didn't get a say in what vaccine. First you got Pfizer, then you got Moderna, the next load might be Pfizer, next load might be Moderna. But right now, all that we're being provided for our patients is the Johnson & Johnson. They get screened on admission. If they are not vaccinated, we offer it to them. They certainly, obviously, as everybody has the right to decline if they don't want it, and many do for a variety of reasons. But then those that want that vaccine, we're more than happy to give it to them once they're fever-free, right? Because you can't give respiratory illnesses, you got to wait till they're fever-free. But then we try to give it to them by the time they go home, if they choose it.
Reston has done really well on your case managers. Our mission over at Zellis, if you've been fully vaccinated, you're not in isolation, you haven't come in isolation. We've been having to do some hospitals where we can't get that COVID vaccine information, but we never have a problem.
Well, that's great. I'll pass that on. I will tell you, just to give you information, Medicare for Herbs yesterday, I didn't know the vaccination status, and they were able to look it up on the state website. So do you have access to that?
I believe our clinicians do, yes.
And that's right. That's an ever-evolving thing. We've had to evolve every day how we've done our care. So now the new question is, okay, are you vaccinated? When were you vaccinated? Was it both of them? And A, do you have your card? Some of them want their card. And B, do you want the vaccine? And so that's information we have to pass along to a lot of providers that need that. I'm not sure we've had a home health company ask for it yet, but certainly that we know that that's in our sphere that we may have to get that information for you.
Do you know if you've seen any Delta variant?
We've had one. So we had a patient that came to Stone Springs who actually was in India with the Delta variant. And of course, he was transferred to Rustin and has since been discharged. But it was just one. And he actually did just come from India. That's why we restrict visiting for COVID patients until we determine if you have a more significant variant. I mean, that Delta variant patient did not get a visitor. Well, mostly because of all his people were testing positive too, right? So we have to be very careful as well for the patients, but also, right, the staff. Now, the majority of the patients, I think the majority of staff at Reston, I want to say 70% at least have been vaccinated. They've chosen to take the vaccine. And then I think there's about 30 that chose not to, which is fine. It's all a choice. What else? No? You good?
Yeah.
And I don't think there's anything on this.
Yeah. No, I think a lot of compliments. Everybody's been good. Hey, come on, man. This is awesome.